When prescribing lunges into our rehab program, we need to consider two primary factors. The first is we need to ensure that our patient truly understands the proper technique and mechanics of how to properly lunge. The second factor is then we need to recognize that we need to manipulate and modify the lunge in a way that addresses their specific limitations. Now, what if I told you you could actually do both of those things simultaneously? That is exactly what we're talking about in this video. We will break down how to advantageously use your arms so that you can achieve both of those goals simultaneously to get the best possible results for your patients and clients. The first way that we can use our arms is to act as a visual reference. Now, what do I mean by this? I want you to educate your patients that their arms are an extension of their sternum. So if the sternum is down, their arms are down. If the sternum is up, their arms are up. Now, why is this important? Well, this addresses the main compensation that we see during a lunge. The main compensation is we see compensatory spinal momentum as they're standing. So it's a compensatory flexion to extension moment at the spine to help the legs overcome the gravity portion, the ascending portion of a lunge. Now, this can happen because they might not understand technique, they might be using weight that's too heavy, or they might just have lower extremity weakness. But regardless of why it's happening, we need to make sure and give them the tools to ensure that this doesn't happen. So, the sternum is an extension of the arms. What do I mean by this? Well, I want you to walk them through this checklist so that they can feel it and understand it. So the first thing I want them to do is to grab a dumbbell or a small foam roller, something that's going to position your elbows right under your wrist. So as you see, I'm not in internal rotation or external rotation as we are in this starting position. It's a nice neutral position. So from here, I want a 90-90 position. So 90 degrees of shoulder flexion, 90 degrees of elbow flexion. And then go through that checklist that we just went through. So when the elbows are down, they're going to go into trunk flexion. When the elbows are up, they're going to go into some degree of spinal extension. And make sure at that point they understand that that happens. How do we fix this? Again, maintain your 90-90 position. I don't want to see your elbows move during the lunge. As they go into that ascending portion, they're going to really want to drop down. But now, as you can see, the arms, the dumbbell, everything's right in front of me. Any sort of variance is going to give me that quick reminder and quick reference that I'm actually going through that compensatory momentum. So this is a really useful way to educate them on improper mechanics and improper form, but also really give them a very easy visual reference so that they can fix it and they understand it when it happens. So that's a really good and useful way to use the arms. Now we can make this even better by combining it with a proper coaching cue. And that proper coaching cue is don't chicken it. This is by far one of my favorite coaching cues because it really clicks for patients. All you have to say is that when you come out of that lunge, so the ascending portion, I don't want to see you chicken it, or don't chicken it. Again, if you think about a chicken, we understand they move in that momentum type way, right? It's a bobbling type of walk. And this is what happens when we have that compensatory momentum. We go down and then fling up to assist our body against gravity. So using the don't chicken it cue plus the visual reference is a really easy way to start to implement a really nice looking lunge. The second way that we can use our arms in a lunge is to have structural influence. Now, when you really look at a lunge and really break it down, we are just looking at gait. We are looking at different phases of gait. The only difference is that in a lunge, we just have greater ranges of motion that we are working through. So to really understand it, let's start at the foot and then let's bring in the pelvis and really understand how the lunge setup that we do can help bias the overall influence of our structure. So why is that important? Well, during your assessment, you will most likely find some sort of internal or external range of motion deficit. We can then take those deficits and strategically employ them into our training. When we do that, we start to work on our limitations in a more of a training atmosphere. So that's why getting really intentional and specific with your exercise selection can go a long ways. So let's break down what's happening at the foot. So we already talked about that we're looking at gait, right? So if we simplify gait, we can think of early, mid, and late stance phases of gait, right? If we're just kind of looking at one limb. That's how it breaks down when we're in a split stance position such as a lunge. Well, we can further break that down by looking at it as ER, IR, ER. So ER for early, IR for mid, ER for late. What that really represents and how that affects our lunge is the shin angle. Because there are different ways you can set up so that you can influence the body to ultimately, like what we just talked about, address the limitations that you found. So let's do a brief review as to how that looks like as it represents to the tibia and the foot. So when we start at early stance phase, this is going to be more of an external rotation bias, and most of us know this as supination, right? Supination occurs during that early stance phase of gait. Well, how does that look at the tibia? It actually produces a negative shin angle, right? Because we are going to take that step, that heel strike. So the tibia is back. So we're thinking negative shin angle, and we're thinking supination or external rotation bias. So what does that mean? If someone struggles with ER in the early range of motion, we want to set them up into this bias. Well, we can further look at mid stance. So as mid stance comes, we start moving towards more of a neutral tibia. So the shin angle is neutral. The tibia is right over the foot. We know that we see more of a pronated state in the foot. We move into more pronation, and this would be synonymous with internal rotation. Again, we have IR limitations on our assessment. We want to start thinking, how do we implement these IR-based strategies into our exercise selection, or in this case, a lunge. Finally, we look at late stance. Late stance is going to drive more external rotation through a supinated foot. What that looks like is we go to that toe-off position, and we're going to have a positive shin angle, right? So as we go into that toe-off, that tibia is going to be driven forward. So again, late range of motion limitations, we can start looking at late stance phase of gait external rotation measures. So again, really impactful as to how to understand that and how the tibia and the amount of knee flexion you're getting during a lunge can influence your patient. So with that being said, let's go through how that looks like at the pelvis. And let's reference the right leg being back, the left leg being forward. So if you think about, you're in a split stance position with the left leg forward and the right leg back. In this position, we are in more of an IR bias. Why? Because we are turned towards that right side. So the right side's in an IR bias as we start, the left side's in more of that ER. As we continue and go into our lunge, this is when we start to see those different phases of gait, and we will see it as it represents to the sacrum, the spine, and then our knee angle like we already discussed. So as we talked about, that negative shin angle is going to be associated with ER, neutral shin is going to be IR, and then a positive shin angle is going to be ER. What you really want to focus at the pelvis is, where are you in the point of the turn? And what we can do is we can use our arms to strategically produce an IR or an ER bias. So if we are in this type of position, so our right leg is back, our left leg is forward, when we go through our lunge, if we have a contralateral load, so if we are reaching with our contralateral arm, so contralateral in this example would be the right side. The forward leg is the leg that we are working. So if we are working a contralateral arm reach or holding load, it's going to induce a turn. That turn is now working on IR-based mechanics. Now, we hit different levels of IR and ER as we go down. A quick note is when you get around that 90 mark, we actually go into a IR bias, but I talk about that a lot more and in a lot more detail in the Performance Redefined course. But for this video, I want you to just think the contralateral load is going to increase the sacral rotation and the spinal rotation towards the front leg. That rotation is now moving this left side into more of an IR bias. We are turning towards that side, we are weight shifting over there, we are in the act of IR. So a contralateral load improves IR. So someone who has limitations during their assessment with IR movement, it would be beneficial to work on IR-based strategies. Now, if we look at the exact opposite, to improve external rotation measures and to bias external rotation measures, we are going to hold the weight or reach on the ipsilateral side. So same scenario, right leg back, left leg forward. If we hold on the ipsilateral side, so the left side, it's going to have a yielding effect. It's going to slow down that rotation. It's essentially going to rotate the sacrum back and rotate the spine back, and it's going to increase the amount of space, right? So if I'm here, instead of the forward motion that we saw with the contralateral load, if we hold ipsilateral, it's going to maintain more of this neutral and then potentially even move away, right? So once we start turning back towards that right side, as you see the spine and sacrum moving to the right, we are increasing that external rotation bias. And we do that with a ipsilateral load. So again, bringing it back to our assessment, utilize what you find on the assessment. If you find ER limitations, this would be more beneficial to use your arms strategically so that you can get the effect you want during a lunge. The third way that we can use our arms during a lunge is to influence airflow. Now, this is something you may not be thinking about when you are putting a lunge into your program. However, most of us have patients that have mobility issues in that mid to upper back. So why would you not want to incorporate and improve that as you're doing a lunge? Additionally, what you'll find is that when you start addressing these restrictions above, you tend to have better outcomes, range of motion, and strength at that lower extremity during the actual lunge. Now, when we think about breathing, you really need to understand that air is always moving from concentrations of high to low. So that means that it's always seeking the path of least resistance. So that's one way it works. How we actually put that into use is through compression and expansion. So when a muscle contracts, it's going to compress. So what I want you to think about is that compression is going to produce resistance. It's going to produce a lot of that concentric compression. So if we take a breath while influencing a concentric contraction, the air is most likely going to move away from that area. So we can beneficially use our arms with our lunge to start to influence airflow and to start to get more expansive properties for these patients that have mobility restrictions. So we really need to start to grasp that we have an ER, IR, ER range of motion spectrum at the shoulder. How it breaks down is we have 0 to 60 is more of an ER bias, 60 to 120 is more of an IR bias, and 120 to 180 is more of an ER bias. Now in this video, I'm not going to go into all the details of that. I go into that into significant detail in the Performance Redefined course. However, it is useful for you to know that we have that reciprocating motion at the shoulder as well. So, now that we understand that, let's understand how we can start to reach and use our arms to influence airflow. So what I suggest is you get a foam roller, a dumbbell, something that will keep the arms in a neutral position. And then all we're going to do is use the principles that we talked about. So compression, expansion, ER, IR. And for the first one, 0 to 60, I want you to really think about, we're in this position, and again, 60 degrees as far as the elbows, we are going back and remembering that the sternum is an extension of the arms. So we're looking to reach those elbows forward. We're going to get compression anteriorly. We're going to open, think of the scapula opening up, right? So we are getting more of that expansion at that scapula. And because we're at that 60-degree reach, we're actually going to start to influence higher areas, such as T2 to T4. Think upper trap, think of levator scap, these areas that get really bogged down on our patients. So when we're going into our lunge, we maintain our reach at that 45 to 60-degree angle, and then we focus on inhaling in there, and we're really going to start to influence that limited mobility in that T2 to T4 area. The next thing we can do is focus around that 90 mark. Now, if you are in a prone position, we tend to get anterior expansion. If we are standing doing a lunge, you will most likely get more of a posterior expansion. And the same thing happens here. We're going to reach forward as we are going into our lunge. You're already doing this if you're following the first reference we talked about, but now we add that slight reach. It's going to open up the scapula a little bit. It's going to promote expansion there, and then we work on breathing with good form during our lunge. And then the last, typically not as often utilized, is you could be in that higher range. Typically that's not as utilized because it's going to pull you into a lot of spinal extension, but you could be in this upper end range as far as the reach goes, and then going into your lunge. And when we do that, we're putting a lot of length and eccentric orientation on areas of T8 and below. Think about the lats. They're going to be lats and lower traps are going to be big time players here. So now you should know 3 ways to beneficially use your arms during a lunge. And again, it's really going to help make your exercise prescription and selection very intentful. It also is going to make you go back to your assessment and see what you're really working with as far as the limitations go, and then really making it specific for your patients and clients. So I challenge you to keep up with these 3 things, always stay intentful with your exercise selection, and continue to work with purpose.